Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. I'm sure you're familiar with anatomy. What are we looking at? No, not just a simple answer. Look real deep in there. In that right nasal. Do you see that nasal polyp? We're going to be discussing this and much more in Nasopharynx and Larynx Pathology. This is covered in your book, Medical School Pathology and Step 1 Review. Updates are on the website. I'm sure you know this by now because you're not a procrastinator. First off, let's talk about the nasopharynx. One of the main conditions that you need to be aware of is rhinitis. Rhinitis is inflammation of the nasal mucosa, as shown in this cartoon on the right side of the screen. Adenoviruses are the most commonly known cause of rhinitis. Common symptoms of rhinitis include sneezing, congestion, and runny nose. Rhinitis is a type 1 hypersensitivity reaction, such as one in response to pollen. And this is what causes allergic rhinitis, which is a form of rhinitis. Rhinitis is characterized by an eosinophil-filled inflammatory infiltrate. You remember, eosinophils are bilobed. Patients with eczema and asthma are classically susceptible to rhinitis. Rhinitis is associated with asthma and eczema. You remember that triad? With regards to rhinitis, the mechanism of non-allergic rhinitis is due to an imbalance between the sympathetic and parasympathetic components in the nasal mucous membranes. And there are certain pathological changes that occur in non-allergic rhinitis, which begin with an irritant exposure, then replacement of the ciliated epithelial cells by goblet cells, which leads to increased mucin hypersecretion and decreased mucociliary activity. And here is every person with hay fever's nightmare, an extremely magnified image of pollen. And here is just a various representation of H&E stains showcasing infectious rhinitis. And in regards to allergic rhinitis, not all the time, but sometimes, just for curiosity's sakes, you can have a component due to increased eosinophils. You can have a component that has increased mast cells, others where neutrophils are actually predominant, and others where there's a mix between the cells, such as eosinophils and mast cells. And this is beyond your scope, but keep in mind that in order to recognize abnormal, you first need to see normal, right? So always remember what your normal histology looks like. Now, I'm sure it's tough with these images, but I believe in you that if you look at A, you can see some of those cilia, right? You see them. You should consider pathology. Here's that nasal polyp again. Yikes. I don't want to torture you with this, but remember that nasal polyps are edematous, polypoid, and can be irritated in the nasal mucosa. Nasal polyps are classically associated with cystic fibrosis, aspirin-intolerant asthma, and recurrent rhinitis. And while we're on the subject, let's talk about cystic fibrosis for a little bit because that comes up a lot. You remember that cystic fibrosis is a genetic condition that affects multiple organs, especially the lungs and the digestive system, and even the reproductive system, right? Patients with cystic fibrosis typically have diarrhea, foul-smelling stools, greasy stools, and they're greasy because they're losing their fats, right? And they're losing all that fat, so they're losing their fat-soluble vitamins, right? Now, which of those fat-soluble vitamins that are lost in patients with cystic fibrosis will lead them to having clotting abnormalities? Vitamin K, right? Vitamin K, because that's involved with 2, 7, 9, 10, protein C and protein S, right? You know that because we talked about it. I know you remember that. That's why I'm proud of you. And the other fat-soluble vitamins, since we're talking about it, A, D, E, and K, right? And what's the mutation with cystic fibrosis that's most common? Delta F508, right? The loss, or I should say deletion, of phenylalanine. Never forget cystic fibrosis. It shows up a lot in the real world, and it shows up a lot in tests. So it's one of the must-knows for sure. You're definitely going to see it. Now, regarding nasal polyps, 10% of asthmatic people have aspirin-intolerant asthma, which is defined by the triad of asthma, nasal polyps, and aspirin-induced bronchospasms. Here we have imaging from a patient utilizing a CT scan that shows a nasal polyp. And here we have an H&E representative section of a nasal polyp. Note the polypoid fibrous stroma, and you can even see some of the respiratory epithelium outlined near the bottom right. And here we have somewhat of a mimicker, a pathologic finding in an early organized thrombus, as well as in B, the H&E stain of that. But keep in mind, this is an Angiomatous nasal polyp. Now let's talk a bit about Angiofibromas. What's an angiofibroma? Well, an angiofibroma consists of large blood arteries and fibrous tissue that make up this benign tumor of the nasal mucosa. And it's typically found in adolescent males. And I'm sure you can imagine why by looking at this H&E with those dilated vessels filled with red blood cells. It should be easy to understand that severe epistaxis is associated with angiofibromas. Now this is bad. This is a nasopharyngeal carcinoma. Nasopharyngeal carcinomas are a malignant type of tumor of the nasopharyngeal epithelium. To the right, we can see a FDG PET CT scan that is beaming for a nasopharyngeal carcinoma. Epstein-Barr virus may be a cause of nasopharyngeal carcinoma. Nasopharyngeal carcinomas typically occur more so in Chinese adults and African youngsters. Here we have an H&E representation of a nasopharyngeal carcinoma, specifically in this image, the undifferentiated type at low power. Keep in mind that the histology of nasopharyngeal carcinoma typically shows pleomorphic keratin-positive epithelial cells which are poorly differentiated squamous cell background, with a lymphocytic background. Nasopharyngeal carcinoma frequently presents with cervical lymph node involvement. So keep this on the differential for cervical lymph node involvement. What else should you think of at the top of a differential for a, let's say, young adult with cervical lymph node involvement? Perhaps mono, right? Perhaps Hodgkin's disease, right? You have nasopharyngeal carcinoma on that differential now as well. Keep it in your back pocket. And here we have another H&E representation of a nasopharyngeal carcinoma. Do you see all the lymphocytes? Do you see the undifferentiated squamous component? Fantastic. And this is just a higher power, closer magnification. Looks real ugly, I don't like it. Take me somewhere else. That's a bit better, this will do. This simple micrograph showing a nasopharyngeal carcinoma. And again, I want you to be able to recognize normal. Now you might be saying, Dr. Anthony Wheeler, you showed us an image, you wanted us to recognize the cilia, we didn't see it. Well, this is your payback. Because you look to the left here, now I believe in you. I know you can do this. I know you can point out the cilia on that respiratory epithelium. Do you see it? You see the little finger-like projections? Let me know if you see this. Figure out a way. I need to know. I'm curious now. So let's move on. Let's discuss the larynx. Starting with a commonly tested entity known as acute epiglottitis. So future head neck doctors, H&Ts, you're going to be seeing this basically daily. Note the swollen epiglottis, and we visualize this with a laryngoscope, right? Now remember, acute epiglottis is the inflammation of the epiglottis. Haemophilus influenza type B is the most typical cause of acute epiglottitis, especially in non-immunized children. There is a buzzword associated with acute epiglottitis called the Halloween sign. You might see that sometimes. Common symptoms of acute epiglottitis include fever, sore throat, dysphagia, drooling, muffled voice, and inspiratory stridor. Acute epiglottitis can possibly lead to an airway obstruction, so that's a potential complication. Now you'll definitely see this. You might not see the Halloween sign. That might be a little too esoteric for radiologists, but at your level, you should definitely recognize the thumb sign. If you see that on an X-ray, boom, you know it's acute epiglottitis for sure. You can count on that. You will see it. Now let's talk about laryngotracheal bronchitis, better known as croup. This shows up everywhere as well. Laryngotracheal bronchitis is an upper airway inflammation. Note this sign, which you will see. It's a steeple sign. You'll definitely see this. A steeple sign is associated with croup, also known as laryngotracheal bronchitis. Don't forget, the technical name for croup is laryngotracheal bronchitis. Now, this condition is commonly caused by the parainfluenza virus. The parainfluenza virus is the most frequent cause of laryngotracheal bronchitis. Laryngotracheal bronchitis presents with an inspiratory stridor and a harsh barking cough. Now let's talk about vocal cord nodules, also known as Singer's nodules. Vocal cord nodules are benign growths on the vocal cord or cords. And they result typically from the overuse of the vocal cords, hence why they're called Singer's nodules. Hoarseness is a common finding in patients with vocal cord nodules. Vocal cord nodules typically are bilateral. The histology of vocal cord nodules typically shows connective tissue that is in a state of myxoid degeneration. Treatment of vocal cord nodules is to silent, talk less, allow the vocal cords to recover. Here we have the anatomy of the region near the vocal cords, right? You remember this, you've seen this at your level. You remember the cricoid cartilage, I'm sure. You remember the vocal folds and the vestibule, right? Now here we have an H&E section from a vocal cord nodule that microscopically showed vocal cord actinomycosis. So this is actually a vocal cord actinomycosis mimicking a laryngeal tumor. Now let's talk about laryngeal papillomas, also known as laryngeal papillomatosis. You might see that. They're the same thing. Laryngeal papilloma is a benign papillary tumor of the vocal cord. To the right here, you can see a squamous papilloma of the larynx, which is a laryngeal papilloma. And this one happens to lack atypia. And note that HPV tends to be associated with these lesions. Here we have a CT volume rendering of the upper airway in a person with tracheobronchial papillomatosis. Remember that patients with laryngeal papillomas may present with a raspy voice. Now, laryngeal papillomas are often single in adults, but multiple in children. HPV 6 and HPV 11 are common causes of laryngeal papillomas. Now let's talk about an entity that is seen a lot. This is laryngeal carcinoma. Laryngeal carcinomas are epithelioid malignancies that affect the larynx. Squamous cell carcinoma is the most common type of laryngeal carcinoma. Laryngeal carcinoma typically develops from the vocal cord's epithelial lining. Symptoms of laryngeal carcinoma include hoarseness, coughing, and stridor. And risk factors, as I'm sure you know, for laryngeal carcinoma include alcohol use and tobacco smoking. And keep in mind that laryngeal papillomas are an uncommon predisposing lesions that may progress to laryngeal carcinoma. And with that, you've completed another high-yield lecture. Give yourself a pat on the back because you're doing great. You're doing what you need to do to ensure your success, and I'm proud of you. Keep up the good work, and I'll see you later. Oh, and let me know if you have any questions, comments, or concerns, because I'm always here to help you. I want to see you win. Take care.